Good evening, dear colleagues and professors. It's our pleasure to welcome you to our annual resident session. We invite you all to enjoy our session and learn from our unique, highly selective cases. Tonight, we will have 3 winners, so please, after each and every case, scan the QR code and score from 1 to 10 for each case. So let's get started. Let's welcome Dr. Maria William. She will represent her thesis to us.
Good evening. I'm Maria William Bushra, Assistant Lecturer at the Radiology Department in Shams University. I will present my thesis briefly under supervision of Prof. Dr. Shaima Abdel-Sattar. The title of a comparison of post-contrast T1 and post-contrast flare sequences in detecting intracranial pathologies in pediatric. Let's introduce as we divide the intracranial pathologies as intraaxial and extraaxial. Extraaxial refer to any lesion outside the brain parenchyma. Intraaxial in the brain parenchyma itself. We use the MRI, gadolinium contrast. Briefly, the contrast enhanced T1 provide us a good anatomical information. Well, contrast enhanced T1 provide us detection and the characterization of various intracranial pathologies. But ليه احنا فكرنا في الكونتراست انهانسد فلير؟ اكيد لان في شويه دروباكس موجوده في الكونتراست انهانسد T1. منهم ان المننجيز is slightly enhanced after intravenous contrast enhanced injection، وده بيبقى slightly confusing. ولما بحقن الصبغه في البوست كونتراست T1 بلاقي difficult to separate المننجال enhancement from adjacent vessel. We can't differentiate between the pathological meningeal enhancement from cortical veins. بلس ان حاجه مشهوره جدا ان بيبقى في flow related artifact بتبقى في البوست كونتراست T1 ودوت بيهامبر proper assessment في certain regions في البرين اللي هي البوستيريور فوسا. احنا فكرنا في البوست كونتراست فلير. طب ليه البوست كونتراست فلير؟ نمبر 1 علشان خاطر البوست كونتراست فلير اي ليجن باكسهابت انهانسمنت في البوست كونتراست T1 هيكسهابت انهانسمنت في البوست كونتراست فلير. بلس ان الفلير فيه ميزه ان هو doesn't allow contrast enhancement في الفيسلز، فكأني بالظبط شايفه observable T1 contrast with nullifies السيجنال بتاعه CSF. بلس بقى ودي الستريسنج بوينت ان الكونتراست انهانسد فلير بيديتكت اني لو جادولينيوم كونسنتريشن. احنا فكرنا في ان احنا هنشوف طيب الكونتراست انهانسد فلير دوت هيقدر يفيدنا بايه. طب قبل اي حاجه ايه هي النورمال انهانسنج ستراكشرز الموجوده في الكونتراست انهانسد فلير؟ احنا بنشوف في الطبيعي خالص في النورمال بنقدر نشوف البيتويتري انفانديبلم بعد الكونتراست، الكورويد بليكسس الكافيرنس ساينس. تمام؟ احنا اشتغلنا على البيشنتس في الام ار اي عندنا في الدمرداش، اشتغلنا على 37 بيشنتس بيدياتريك ايج جروب و اندر انكلوجن اكسكلوجن كرايتيريا. اشتغلنا على 3 تسلا و1.5 تسلا واشتغلنا بالبروتوكول ده. ضفنا ال 3 دي تي 1 ب انتر سلايس جاب 0 عشان نتكت اني ليجن، وزودنا في الاخر 3 دي تي 1 بوست كونتراست و 3 دي فلير بوست كونتراست، وعملناه ديليد علشان لقينا ان الديليد بوست كونتراست فلير از مور سنسيتيف. طيب اشتغلنا ازاي؟ اشتغلنا ان احنا عملنا ايمج اناليسيز تو كاتيجوريز. اول كاتيجوري لو ده ماس ليجن انا هعمله كواليتيتيف وكوانتيتيف اسسمنت. الكواليتيتيف ده هديسكرايب النمبر واللوكيشن والكونتراست انهانسمنت بتاع الليجن موجود فين بالظبط. الكوانتيتيف هقيس حاجتين، هقيس اول حاجه كونتراست انهانسد اندكس وهقيس ليجن تو باك جراوند ريشيو. الكونتراست انهانسد اندكس ده هشوفه في البري بري كونتراست فلير وبوست كونتراست فلير. والليجن تو باك جراوند ريشيو انا هقيس هحط روي على الليجن واشوف الانهانسمنت قد ايه بالنسبه للباك جراوند. زي هنا بالظبط ده اكزامبل للكونتراست انهانسد، ده ايه بري كونتراست فلير وده بوست كونتراست فلير، وكنا بنحسب بالسبستراكشن نشوف الانهانسد اندكس قد ايه. والليجن تو باك جراوند بجيب نفس الليفل بالظبط في البوست كونتراست تي 1 وبوست كونتراست فلير وبقيس الليجن تو باك جراوند ريشيو. طيب ده اول كاتيجوري. ثاني كاتيجوري لو كان منينجال انهانسمنت هعمل ايه؟ ده ما فيهوش ليجن تو باك جراوند، انا بحط روي وبقيس السنجل بيكسل سيجنال انتنسيتي على المنينجال انهانسمنت ده وبقارنه بالفاستر انهانسد في الكرويد بليكسس في الفنتركل زي الصوره دي كده بالظبط. طيب احنا اشتغلنا على 17 حاله انفكشن انفلاميشن، 12 حاله تيومرز، وكان في هيموريدج. لقينا بالستاتستكس ان في no statistically significant difference regarding the number of lesion between البري والبوست. يعني بالنسبه للبري والبوست بالنسبه للنمبرز اوف lesion ما فيش significant statistical difference، لكن ان احنا لقينا ان contrast enhanced index was significantly higher في البوست contrast flare. احنا دي a case of 8-year-old boy pathologically proven retinoblastoma. MRI was done, multiple cerebellar metastatic lesion. زي ما احنا شايفين ايه هنا كان بوست كونتراست تي 1، ما كناش شايفين ليجنز خالص. بي ده بري كونتراست في حاجه فينت قوي، ودي كانت الحاجه الحلوه جدا للرساله اللي هي ضافتها، ان احنا شفنا الانهانسمنت واضح بتاع الميتاستاتيك ليجنز باينه جدا في السيربيلم في البوست كونتراست فلير. Okay, I will explain the schedule related to the cases. Number one, a case of meningeal enhancement. We can all see the enhancement of the meninges. This patient was diagnosed with meningitis and took the proper treatment and discharged after this. A case of subependymal nodule. As we can see, A, the post contrast T1, B, post contrast enhanced flare, we can see the difference of enhancement. ده a lesion, 12-year-old boy, pathologically proven astrocytoma. MRI was done right temporoparietal and occipital heterogeneous soft tissue mass with the hemorrhagic cystic changes. Contrast enhanced T1 number picture A, picture B contrast enhanced flare. البوست show heterogeneous enhancement with lesion to background ratio assessment لانها اعلى بكتير في الفلير 3.1 وده 3.7. وده لان اللي احنا لقينا ان البوست كونتراست فلير كويس جدا في حالات الهايبو فاسكولارايزد تيومرز، لان هو بيديتكت any minimal concentration من الجادولينيوم enhancement. A case of pathologically proven high-grade glioma seen in post-contrast flare, post-contrast T1. A 6-year-old boy diagnosed with medulloblastoma underwent debulking surgery. A follow-up MRI of the brain with contrast was requested. As we can see, enhancement of the lesion is more intense in post-contrast flare, picture number B, regarding in comparison with the pre-contrast flare. As we can see, the same calculating the contrast to background ratio, lesion to background ratio. Case 2, a 7-year-old girl complained of nystagmus and secondary inability to walk. Diagnosed with brainstem encephalitis. We can see the enhancement of the midbrain more intense in the contrast enhanced flare. A 10-year-old boy with pathologically proven craniopharyngioma. We can see the great difference of contrast enhancement between contrast enhanced T1 and contrast enhanced flare. MRI shows scattered intraparenchymal cerebellar lesion. We can see in both cerebellar hemispheres. Pre and post contrast T1 sequences at the same level show faint enhancement in post contrast T1. Pre and post contrast flare at the same level show lesions are more evident in post contrast flare. As a conclusion, compared to contrast enhanced T1 and pre-contrast flare, contrast enhanced flare was found to have better lesion detection, higher contrast index, enhanced index, and lesion to background ratio, especially in many cranial intracranial pathology detection of intracranial metastases, follow-up brain tumors, and after therapy, hypovascularized brain tumors, also in superficial parenchymal lesions, inflammatory brain conditions, and the detection of meningeal enhancement and extra axial lesions. Finally, even though your plan might be pretty, God's plan would hold a beauty beyond your imagination by Raif Ahmed. Thank you very much, Maria William.
Please don't forget to scan the QR code to score the case. Coming up, Dr. Asim Karam will present pediatric CNS infection.
Assalamu alaikum. I'm Asim Karam. Our talk will be about imaging of pediatric CNS infections. This presentation is under supervision of Professor Dr. Shama Abdel Sattar. Regarding the prevalence of CNS infections, it affects over 1.2 million children globally each year. Correlation between clinical data and radiological features help in diagnosis and treatment. Pediatric CNS infections are either congenital or acquired. Acquired are classified by type of pathogens to bacterial, fungal, viral, and parasitic. We will go through a few cases demonstrating key imaging features of common CNS infections, all proven clinically and laboratory. Case 1, a 7-year-old male presented with fever and disturbed conscious level. CT brain shows this cystic lesion with surrounding edema, vasogenic edema, having this finger-like configuration, as you can see. MRI confirms the cystic nature of the lesion, low T1, high T2, with surrounding vasogenic edema. It shows central true diffusion restriction denoting pus content with smooth peripheral enhancement in post-contrast. These are typical features of vasogenic abscess: central diffusion restriction plus smooth peripheral enhancement in patient presented with fever, considered vasogenic abscess. Our next case, a 14-year-old female presented with headache, fever, and convulsions. CSF shows lymphocytes suggesting viral cause. In MRI, we have this abnormal high flare signal seen in left temporal lobe, insular cortex, thalamus. T2 shows cortical swelling in the same sites. Look to this insular cortex and compare to other side, also the left temporal lobe. Facilitated, not restricted diffusion is noted. Please note the subtle high signal in ADC, not the low ADC signal of true diffusion restriction. The diagnosis of this case was acute herpes simplex encephalitis. Our next case, a 2-year-old male presented with disturbed conscious level and convulsions following upper respiratory tract infection. An important point in patient's history is it followed upper respiratory tract infection. Our CT shows bilateral thalamic lesions, hypodensities actually, here in CT. In MRI, we can appreciate that there is bilateral thalamic low T1, high T2 lesions, and in T2 star, we have the pluming artifact denoting hemorrhagic component. These bilateral thalamic hemorrhagic lesions are features of acute necrotizing encephalopathy, which causes dramatic neurological symptoms, usually post-viral infection. Our next case is 14-year-old female patient presented with disturbed conscious level. In CT, we have this right isodense thalamic lesion with scattered areas of vasogenic edema in the brain. In MRI, we have multiple lesions with low signal in T2. This is an important point. Low signal in T2 with surrounding edema appreciated more in the FLAIR. Such lesions show peripheral, not central diffusion restriction. We can see that in diffusion, we have the high signal in the periphery, not the center. And in post-contrast, T1 shows peripheral enhancement. You can appreciate these lesions and also here, here, and here. This case was diagnosed as CNS tuberculosis. Regarding cerebral TB, it can affect either the meninges or brain parenchyma. In TB meningitis, we see thickening and enhancement in basal meninges, like we can see here. And the parenchymal affection is usually tuberculomas, the lesions of low T2 signal, and TB abscess. TB abscess, which is a rare form, its radiological appearance is identical to pyogenic abscess. In context of CNS infection, there is an important differential diagnosis of lesions showing low signal in T2, which is fungal infection. Like this case, with similar appearance, the low T2 signal and peripheral enhancement, it was diagnosed as fungal. Note the low T2 signal and peripheral enhancement, as we said. In practice, we commonly suggest both of TB and fungal as differential diagnosis. Our next case is 12-year-old male presented with fever and vomiting. In CT, we have this cystic lesion with no significant perilesional edema, but it causes mass effect. MRI shows that there is a well-defined intraaxial thin-walled parieto-temporal cyst with no perilesional edema, no true diffusion restriction, no post-contrast enhancement. These are features of a hydatid cyst, and it was proven post-excision. Most cerebral hydatid cysts are located supratentorial in MCA territory. In the absence of perilesional edema and enhancement with a large solitary cyst with mass effect, we suggest hydatid disease. Our last case is a 14-year-old male presented with diplopia after otitis media. In MRI, we have this opacification of mastoid air cells and middle ear cavity, noted by high signal in T2, with post-contrast enhancement. True diffusion restriction, high diffusion and low ADC is noted in mastoid air cells also. And the extension of the infection into the petrous apex, which is called petrous epicitis, we use this term, noted by abnormal high signal and true diffusion restriction as well. Filling defect is seen here along the right sigmoid sinus, which shows true diffusion restriction. And the abnormal signal is seen extending into the right internal jugular. Note this dot in diffusion weighted images corresponding to the site of jugular foramen here in conventional T1. This patient also demonstrated signs of increased intracranial tension. Note the tortuous optic nerve with increased perioptic CSF. The diagnosis of this case is acute automastoiditis and apical petrositis complicated by sigmoid sinus and internal jugular vein thrombosis. In sinus thrombosis, it's a frequent complication of automastoiditis. We also check for venous infarction and signs of, there is no venous infarction here in this case, but we always look for it. Signs of increased intracranial tension secondary to sinus thrombosis as the case showed. Finally, you may read this emotional quote written by our dear colleague Raif Ahmad. Take your time. Thank you.
Now we have series of short but unique cases presented by our talented residents. Please don't forget to scan the QR code for the second case.
Good evening, dear professors and colleagues. I am Mariam Mahmoud, radiology resident, class 21. I will present an interesting female imaging case under supervision of Dr. Marwa Muhammad and Professor Dr. Amal Ibrahim. At the beginning, the history was misleading and insufficient. It was 32 years old female presenting with epigastric pain not related to meals, relieved by vomiting and pelvic pain for 5 months duration. No other systemic manifestations, long history of left pelvic, non-functioning kidney, medically and surgically free. Pelvic abdomen ultrasound was done outside Eldemir Dash, revealed left pelvic kidney. CTUT at Eldemir Dash revealed left kidney is not visualized with pelvic cystic lesions for further MR evaluation. Dynamic renal scan done also at Eldemir Dash revealed non-visualized left kidney. I will play MR sequences fast because of session time, but my request for you all is to count how many lesions you can identify, where and what are the lesions. Okay? Are you ready? Here is the axial T1 images. وده فيديو المفروض. And here is the axial T2 images. Here is the coronal T2. And here is the sagittal T2. I guess you must need fat suppression sequences. So here is T1 fat sat and T2 spare sequences. So our first lesion is that the right adnexal lesion, right adnexal convoluted multilocular lesion with incomplete septy, displaying low T1, high T2, and T2 fat sat signals, mostly representing the right dilated fallopian tube. This lesion is a right hydrosalpinx. The second lesion was that the left adnexal lesion, convoluted, also multilocular with incomplete septy, with content showing intermediate to low signal on T2, which is the T2 shading, and high signal in both T1 and T1 fat sat, denoting blood content. This lesion is a left hematosalpinx. The third cystic lesion was ovarian in origin, that shows intermediate to low signal in T2, high signal in T1, and T1 fat sat, mostly representing left ovarian endometrioma. The fourth lesion is that the hypointense myometrial lesion that shows low T1 and T2 signal. This lesion was uterine fibroid. Abdomen cut reveal absent left kidney and that gastric wall, mild diffuse thickening denoting gastritis. So our diagnosis for this case is endometriosis, right hydrosalpinx, left hematosalpinx, left ovarian endometrioma, right uterine wall interstitial fibroid, absent left kidney, and gastritis. And our differential diagnosis for the right adnexal cystic lesion was ovarian cyst, para-ovarian cyst, inclusion cyst. And for the left adnexal lesion is endometrioma, according to different MR sequence signal. So we have called the patient again to get more detailed history. That was, the patient is virgin with very painful regular cycles for which she took non-steroidal anti-inflammatory drugs. That was the epigastric pain cause. And that intensifies the diagnosis of endometriosis. And here is the ACR criteria for dealing with pelvic pain, starting with ultrasound, then MR or CT pelvis are recommended. So our learning point, taking detailed obs and gynae history from patient with suspected pelvic lesion is a must to avoid misleading diagnosis. Identify pelvic organs anatomy to detect where is the lesion. T1, T2, and T1 fat sat suppression are crucial sequences to identify what is the lesion. Our dear colleague Raif Ahmed wrote this quote saying, if you love what you do for a living, even routine becomes meaningful. Thank you.
شكرا يا دكتوره مريم. والحقيقه انا عايزه انوه حاجه، الكيسز اللي هتشوفوها دلوقتي كلها دي كانت the best cases of the year. احنا في الجراند ميتنج كل شهر بنعمل مانثلي ميتنج بيتعرض فيه احسن الحالات اللي اتعرضت في الشهر ده من all subspecialties، وبعدين بنعمل فوتنج على البيست كيسز كل شهر، والكيسز اللي شفناها اللي هنشوفها النهارده دي كلها the best case of the last year. فان شاء الله تبقى مفيده وتبقى تعجبكم ان شاء الله.
Can we call for Mai Sami? Again, please can you scan the code for the third case?
Hello everyone, my name is Dr. Maysami Arbab Saeed. Today I'm going to present interesting cases about advanced abdominal ectopic pregnancy with a favorable maternal and fetal outcome under supervision of Dr. Amal Ibrahim. So starting with the history of the patient, we have a 26 years old prima gravida patient at the 33-week gestational age. She came complaining of the antepartum hemorrhage for 10 days of the regressive courses. And then the patient said that she has, and she was in the regular antenatal care. And on examinations, she was hemodynamically stable with a vital sign. Actually, ultrasound was requested for this patient, but it's inconclusive. So the MRI was requested. So surprisingly, what our MRI finding shows, it shows there is an extra-uterine, intra-abdominal gestational sac that's located outside the uterus. The uterus is appear gravid and empty. So this is the sagittal T2 where its imaging shows single intra-abdominal extra-axial uterine gestational sac containing the fetus, pointed with the blue arrow. And the uterus is appear empty and gravid due to the action of the hormones during pregnancy. Coronal sections of T2 weighted imaging show single intra-abdominal extra-uterine gestational sac located in the left side of the abdomen of these patients and containing the fetus, and the fetus is at a breech presentation at the time of the examinations. The placenta is located at the left, in the right side, and also here the uterus appear empty and gravid and shifted to the left side. The axial T2 weighted image showing there is a right pelvic placental tissue with the feeding vessels from the internal iliac artery, as pointed with the red arrow. Also branches from the right uterine artery, and also as well as branches from the inferior epigastric artery, green arrow. So the mid segment of the uterus of the ureter have been compressed by the placenta, which leading to the proximal hydroureter and hydronephrosis. So this case is considered as an obstetric emergency. So immediately it terminated surgically by laparotomy, and after that the baby stayed in the neonatal ICU for 15 days. Mother received chemotherapy for the residual placental tissue, which is infiltrated to the abdominal wall and hard to be resected. And finally, mother and fetus were well and were discharged. So this brings us to the MRI protocol during pregnancy. If we suspect there is an abdominal ectopic pregnancy, there is some sequence that are important to be involved to optimize the diagnostic accuracy. We wholly depend on the T2 weighted imaging to evaluate the amniotic cavity, the placental side, the uterine integrity, and also to minimize the motion artifact by the fetus. T2 weighted imaging with a FAST-SAT, also to detect the hemorrhage if there is any hemoperitoneum, and diffusion weighted imaging to identify restriction, diffusion in a trophoblastic tissue if we suspect that.